the reflection to the organ at which they're most approximate. We were talking about these, the organization of smooth muscle, and we said that the radial rings contribute to the formation of these haustral divisions. And we'll look at an Acklin video in just a moment. We'll see that those partitions actually continue into the inferior lumen just a bit. And then this outer layer is a little bit unusual in that it's sort of aggregated or clustered into these three bands. And of course, when we talk about the longitudinal layer throughout the GI tract, what it's doing is it's bending the tract lengthwise. And that, to some extent, is what is being achieved here. With respect to the overall conformation, I'm sure you've also established in your radiology that it never looks like this, right? Folds all over the place. So the hepatic side can be way down, it can be way up. More commonly, the splenic is all over the place. So you shouldn't expect it to have this very nice sort of rectangular organization that you see here. In this particular illustration, you see these little fatty appendages here that sometimes all they're called either epiploic or omental appendages. Their abundance tends to increase with age. As far as I know, there's no particular pathology associated with these. Unlike some of the issues we'll talk about in just a moment, where there will be little exvaginations or little balloons that will appear on the wall of the colon called diverticulum. I think that's all I need to say there. Now, as you can see, there's peritoneum all through here. The cecum itself, okay, a better illustration here. Oh, you can just colon. We've talked about the Penia coli, we've talked about the haustral, we've talked about the fatty appendages. The cecum, I was trying to find it, here we go. So here's a mesocolon. So remember as we described earlier, when you see MES, that just means there's a connective tissue membrane associated with that structure. Technically, there is no peritoneum. I'm sorry, let me say this properly. There is no mesentery to the cecum. There is peritoneum, but there's no mesentery. And you kind of sort of see that here. By mesentery, you can see the arcades and the vasa recta sort of continuing to this point, but not much below that. I think it would be correct, however, to say that the cecum is surrounded with peritoneum. And then, so you can see the mesocolon. This is called the mesoappendix down here, this peritoneal sheath here. Again, the mesoappendix. The ileocecal fold, which is a continuation of that peritoneum onto the cecum, but not really part of the mesentery that provides blood vessels and drainage to the superior structure. And then there's a specialized terminology. I won't say specialized, but there's a different terminology for the blood vessels we'll talk about in just a moment. And you can see our ileocecal valve here, which is not really a sphincter at all. These little corrugations that are continuations of the haustral walls interiorly are no longer called plicae, they're called semilunar folds. They really serve somewhat the same function. And this person has a starfish in their belly. What is that starfish here for? This is the likely location of the appendix along these planes. You can see the relative percentages there. This is McBurney's point here, which we indicate is about a third of the distance from the anterior superior spine to the umbilicus. But there can be variant location or variant placement of the appendix. And these are the relative likelihood that you would encounter it along one of those starfish legs. So as I've indicated, the terminology that is used to describe the blood supply to the colon is a little bit different from that of the small intestine, and need not concern us too much, except that, number one, remember the two major vessels from the aorta that supply the large intestine, Remember the inferior mesenteric and the superior mesenteric and the inferior mesenteric. Notice here, no two sources seem to agree on where they exchange, where the trade-off occurs. As we saw previously, there was a source that put it here, there was a source that put it here, and this particular picture is putting it right here in the descending colon. The other thing I would have you pay attention to is these are called colic arteries. So you have usually what is called a sigmoidal artery. Well, you see a sigmoidal artery coming down here. This is going to be called the right colic artery, and this is the middle colic artery. And then over here we have the left colic artery. The terminology changes even further on this side. I think we have another illustration showing that. Yes, so this is usually for the vessels that are supplied by the inferior mesenteric. These vessels are still called vasa recta, or sometimes just colic radiate arteries. And then notice you have, especially on the attached to the right colic artery, which would be here, and the sigmoidal, you have what is called a marginal artery that gives rise to the vasa recta.
Isn't that left colic artery?
Again, you sort of see the difference here a little more clearly. You can see the right colic, the middle colic, the left colic, the sigmoidal colic, and then out here would be the marginal artery. And then what's distal, I think, is usually still called the vasa recta. Those little vessels that are perpendicular to the wall of the colon. And then the drainage we also talked about a little bit different here, but pretty much corresponding to the scheme we talked about earlier. Drainage, once again, here they're showing it at about the 2/3 of the way across the transverse colon. That drainage going into the superior mesenteric vein, distal to that into the inferior mesenteric vein for the most part. And we'll come back to this portal vein a little later, but that will play an important role. It is worth noticing here in this cadaver image, it's a location relative to the liver and the I'll take that as a hint. We talked about the gut-associated lymphatic tissue. Remember, this is galt and ileum. It's characterized as Peyer's patches. It's going to differ dramatically from individual to individual, depending upon depending upon genetics, variety of factors, but also depending upon the degree to which those individuals have suffered GI tract infections. We don't need to worry too much about the specific pattern. What you're going to find, though, and this is worth noting, is that in the walls surrounding these GI tract tissues, both in the intestine, small intestine, and large intestine, there will be extensive and focal distributions of lymphocytes, lymphatic nodules. And depending upon a variety of factors, they're going to be particularly abundant down here. Why would there be a greater abundance, for example, of lymphatic tissue, gut-associated lymphatic tissue along the colon, for example, than the esophagus? Why would there be so much more here? You do have it in the esophagus. In fact, remember you have, what's your lymphatic tissue up here called?
Thymus?
No, it's a trick question. What is it? Right? You have adenoids, for example, right? Tonsils. And that actually continues. There's a thin veneer, but down here in the ileum, and here it's very thick. Remember, you have 2 or 3 pounds of little buddies. You have 2 or 3 pounds of friends living in your colon that affect your personality, affect your mood, affect your ability to cope with tests. And of course, if they get away, sometimes if they get out of their little housing, their little homes, they can present problems. So that lymphatic tissue in part is designed to minimize that, or to deal with that eventuality. Let's not worry, at least let's not use this illustration to discuss the autonomic innervation of the colon. We will defer this until we get to the pelvic cavity, because this illustration is not very helpful, I don't think, in sorting all that out. We're looking at the hypogastric plexus here. We'll come back to that. And of course, what we see in this illustration is a variety of maladies that can befall for a large intestine. Everything from Crohn's disease, a largely genetic condition that also has environmental components, spastic colon or IBS, irritable bowel, adhesions. And in fact, I had a little video if we had time, we would have looked at showing a surgeon addressing some small intestinal adhesions, but sometimes these can be constrictive and sometimes be a source of considerable pain to your patients. We can see, looking here at colitis, ulcerative colitis, problem in the wall of the colon, inflammation that can also be a source of disease. We talked about the little pockets, these little pouches that emerge in the wall of the colon. Studies show that most of you have these already, and as you age, you're going to get more. And these are little pouches that can sometimes catch the debris of the kind that's accumulating in the colon. And usually not a problem unless they become inflamed, in which case the diverticulosis becomes diverticulitis, and that can be problematic. The colon is, as we've indicated when we were talking about gall-prone bacterial infections, and of course tumors and polyps. Polyps are often considered a precursor to cancer. There's still some debate about that. And sometimes they'll take the scope that goes in there and looks for tumors and so on. They'll look for polyps and chop them off and do the biopsy analysis of those in many cases. Now, I don't think we'll look at this one in the time we have, but let's look at the first part of this little Ackland video, if I can manipulate it with my pen here.
The jejunum.
Just want to look at the beginning of this.
Ileum ends down here. We'll remove some fat to see that better. The ileum joins the large intestine at the ileocecal valve.
He talks about here. This is the ileocecal valve he's talking about here.
Now we'll move on to look at the large intestine, where water and electrolytes are absorbed from the intestinal contents, the contents changing from liquid to semi-solid in the process. The large intestine consists of the cecum and appendix, the colon, the rectum, and the anal canal. The cecum is a blind side passage at the beginning of the large intestine. It hangs downward in the right iliac fossa, lying almost free of peritoneal attachments. Here's the appendix, sometimes called the vermiform appendix. It's a vestigial but potentially troublesome structure. It can lie in a variety of positions. This is its most usual location. Here's a dissection of the terminal ileum, cecum, and appendix that's been opened longitudinally. The ileum projects a long way into the lumen cecum, opening at the ileocecal valve. Here, it's suspended by these two folds of mucosa. Despite its name and valve-like arrangements, this opening is not an effective one-way valve. The appendix opens into the cecum below the ileocecal valve. Here's its opening. To see the rest of the large intestine, we'll again take the jejunum out of the picture. The colon has four named parts: ascending, transverse, descending, and sigmoid. Before we look at these, let's look at the features of the colon that make it different from the small intestine. Here's a typical length of colon. In the colon, the longitudinal muscle isn't continuous. It's gathered into three strips called the tenea coli. Here's one of them. Here's another. The tenea are effectively shorter than the rest of the wall of the colon. They have the effect of drawstrings, producing these bulging saculations. In many adults, these diverticulites develop over time. They're protrusions of mucosa through the muscular layer. Here's the colon on the inside. In between the outward bulges, which are called hastra, these impressive mucosal folds can divide the lumen into separate compartments when the muscle contracts strongly. Seen in close-up, the mucous membrane of the colon is smooth. There are no villi. Here's the opening to that diverticulum. Now,
So make
we'll
sure you
return to
note there are no villi in the colon. The wall is very smooth. We talked about these semilunar partitions that correspond to those partitions between the haustra. And then he just showed you that he's been talking about these diverticulae, and you can see the little pouching there. And that's as much of this as we need. Yes?
Did you say that the tinacola turns into
No. So what we're going to find, and when we talk about this, when we talk about the layers of the GI tract, you're going to have, again, if this is the interior of the GI tract, which I think sometimes we feel that it is. So you're going to have the lumen, then you have the mucosa, which contains the epithelium and some of the glands and so on. Then outside that, you're going to have the submucosa, which also contains glands, fatty tissue. And then in the walls, the distal walls are going to be two layers of smooth muscle. We talked about a radial layer and a lengthwise layer. But in the colon, instead of having a continuous ring of longitudinal muscle all the way around, it gets clustered into these three bands called the tinea coli. So that's all they mean. The diverticuli would be like little bulges, herniations, if you will, in the wall that are quite independent of the tinea. The other little video here is about, you can see the name here. We won't put it this one because that's cheerful. I won't tolerate any cheerfulness in here. This is a diverticulitis resection. So that's one of those little bulges that gets inflamed, and they've actually had to go to the point in this video of removing a portion of the colon to address it. Now, this is one that's a little bit hard to follow, but I wanted you to notice the general procedure. In general, what's going to happen here, as I gather, because I've only looked at this briefly, is they're going to remove a region of the intestine where there's a particular concentration, a particular problem with the diverticula. So he's going to chop, actually I think he says the rectum, he's going to chop a portion of the intestine distally, and then he's going to chop a portion somewhere else, let's just say about that point. And then I want you to pay attention to how they rejoin, because now we have a problem. We remove this, but now we have to join this to this, and that's the fascinating part of this particular procedure.
This video demonstrates a laparoscopic sigmoid resection for mild diverticulitis. The EEA stapler used for the anastomosis is shown here. The handle is on the right, the anvil and the staple cartridge on the left. This close-up shows these two parts of the instrument separated. The anvil will be placed in the proximal end of the bowel. The green unit contains...
So this is the device that's going to weld the two broken segments together. And you can see he's called it a hammer and an anvil. One is going to go in one side, and the other is going to go in the other. One goes up through the rectum, and the other one is placed. You might be interested to see how they place the other portion into the proximal colon.
The staples themselves and a circular cutting knife. It will be inserted in the rectal stump and advanced to the
That's the
transection
part
site.
that goes up.
Once these two units are brought together with overlap bowel, the unit is fired. It places two circular rows of staples and then cuts out a circular donut to provide an open lumen. Initially, the sigmoid is retracted upward and out of the pelvis. The left lateral attachment is opened first. The left ureter here is identified and carefully preserved.
Nice music.
Then the right side similarly. The bowel is then encircled posteriorly and the dissection continued into the pelvis.
This music is horrible. I don't know why.
Two applications of the transverse stapler are used to close and transect the upper rectum.
So that's the cutting. It's called cutting the Kenny G. There's some Kenny G playing in the background.
Yeah.
A small abdominal incision is then made in the lower midline,
You might find this disturbing.
and the sigmoid colon delivered onto the
So the
abdominal wall.
sigmoid colon is taken out of the abdominal cavity.
The upper sigmoid is divided after applying a purse string stapler.
So now you have the two halves that need to be
The
rejoined.
anvil of the EEA stapler is placed proximally with the shaft brought through the suture line.
This is awesome. Wow.
Sort of tightly.
The specimen is removed and the proximal valve returned into the peritoneal cavity.
Put back where it was.
The rectal stump is identified by a staple line. The EEA is inserted through the rectum and advanced to the rectal stump until it distends the staple line. The unit is opened, advancing the shaft through the staple line
So
itself.
that's this is the
The
distal
EEA
end here.
anvil in the proximal valve is passed over the penetrating shaft and snapped in place. The EEA unit is then closed, approximating the two ends of the valve. The instrument is then fired, placing the two circular rows of staples and advancing the circular cutting blade. The pelvis is filled with a saline solution. The rectum is insufflated with air to look for any leaks, which should be shown as bubbles.
We saw that before.
No leaks are seen. The instruments are removed and the trocar sites are closed, completing the procedure. This production was made possible by the generosity of Teresa and Bernard Fondersch.
So I found that kind of interesting. I don't know if those people want their names on that. Yes.
Is that kind of like a similar procedure to do for laparoscopic gastric bypass, when they kind of section off part of the intestine?
Yeah, it would be certainly similar. I don't know if there's a similar device. Have you seen?
Yeah.
Okay. all
No,
right.
I'm unsure of the device.
No, I don't know that that would work with such a small lumen in an intestine. Yeah, with an intestine, I think the procedures I've seen, they simply suture that together because it's smaller and easier to work with. I think it's the size of this that is the issue. They said they have to securely staple it and at the same time remove whatever's left of the interior. And then I guess that whole device then, that's the only part I'm not quite sure about. I guess that whole device then is retracted back through the rectum, pulling the distal component with it. All right, so continuing our discussion of the abdominal viscera, a few others we can touch upon briefly. We're looking at the spleen here. We've talked about the splenic artery. Back here is the spleen. Make sure you, as I've indicated earlier, which quadrant the spleen is located in. The spleen has several physiological functions. It's an important immunological tissue for production of antibodies, differentiation of monocytes, a large repository of monocytes. The spleen also contributes to the recycling of red blood cells. It, along with the liver, contributes to the recycling of red blood cells, basically extracting the heme and then delivering what's called bilirubin to the liver for further processing. And then the spleen is also, as a PA, it's important to keep this in mind, the spleen is also sort of a storage chamber for blood, especially when your patient is in hemorrhagic shock or something. This little additional volume of blood can be drawn on to help to compensate for whatever blood is lost. But of course, the capsule of the spleen is fairly vulnerable, and you've probably heard of individuals suffering a ruptured spleen following a car accident or some athletic injury. And it can get very, very messy. It can just, when it ruptures, it just really fragments in some cases. It just have to be removed the best way possible. But in any case, again, upper left toward the posterior wall, we've talked about some of the ligamentous attachments involving the peritoneum and the importance of the splenic artery and vein extending from the celiac trunk to the spleen. This is a procedure that would not be used um, in the United States currently, but I just wanted to show you what could happen when the spleen is ruptured and how it has to be addressed, at least in a very, well, hopefully not quite this course of fashion in most cases. When an incision is made and this individual has a ruptured spleen, I just wanted you to see the consequences of that. There you go.
Oh shit.
And you just pull out what you can, where you can.
Whoa. How am I supposed to know that's an
I
Indian?
just wanted
It's
you
Hindu.
to see they're pulling out fragments. I just wanted you to help so you can actually roast it.
Critical. Damn.
And the significant loss of blood that can occur.
Yeah.
Yeah, put it on that. So they can very, when splenic rupture can be quite messy, as you can see, there's pulling out fragments now, like little minnows and fish in there. Could have little minnows and fish. I've had that problem. Go for a camping trip and come back with minnows in your belly. All right, let's talk a little bit about the pancreas. We've already talked about the two major functions of the pancreas. The pancreas is an important endocrine and exocrine tissue. That is to say, we've talked about the ability of the islets of Langerhans in the pancreas to generate insulin, glucagon, several other important somatostatin-like hormones and such. The pancreas also generates the pancreatic juice that is critical for digestion of the chyme. That pancreatic juice that we'll see by virtue of a couple of tubules is released into the descending duodenum that we looked at before. It is, as we saw in our discussion of the peritoneum, almost entirely, well, it is entirely retroperitoneal. It's behind the peritoneum, so it is not bound in that fashion. Anatomically, you can see that it has several little parts, but its head, this is the region called the uncinate or head region down here, is sort of nestled in the arms of the duodenum, and then its tail is pointing at the spleen, and of course running through that or proximal to that is the splenic artery and the pancreatic duct. So you can see the parts, the tail here, the body. This is called the head or the uncinate. Uncinate just means it has a hook shape. We've already talked about uncinate components of the, for example, the vertebra. Where they sort of fit together, the bodies of the vertebra. And then be sure you're familiar with the orientation of this and how the tail tends to taper off distally in size. And what we're looking at here, of course, is the pancreatic duct that would extend through the pancreas. And you can see that the pancreatic duct, as it increases in size on its way to the duodenum, branches into two components. There's a main duct and what's called an accessory duct. Superiorly, most individuals have these, not all individuals have the accessory duct. Oops, and that gives rise to two little openings here, a minor and major duodenal papilla, but these are just openings in the wall of the descending duodenum that allow the pancreatic fluid to be received into the duodenum. And you'll also notice, if you look at the illustration down here, that the major or the main pancreatic duct also has a branch that accommodates the bile duct from the liver. So both bile and pancreatic juice are being admitted into the descending duodenum via this hepatopancreatic valve. These little rings, of course, are smooth muscle rings. Those represent sphincters, and that smooth muscle ring is called the sphincter elodi. You'll also notice there are sphincters at the bile duct and at the major pancreatic duct. However, the regulation of those is not well understood. So, as the slide indicates here, you have an anterior perspective and a posterior perspective. Except for maybe a few of these smaller vessels, you should be able to identify anatomically everything that you see there. You should be able to identify, for example, the celiac trunk, the major branches of the celiac trunk that we see here. We see pancreatico-duodenal arteries and so on. Inferior mesenteric vein, superior mesenteric vein. It seemed like there was something else. I know what it was. I also wanted you to note this structure. Now, at this point, we've already talked about the bile. We've talked about the fact that all of the digestive system blood is being taken to what is called the portal circulation up to the liver. And what we're looking at there, we talked about that little foramen that you could be palpated between the liver and the duodenum. This is called the portal triad. You can see there are three important components here: the common hepatic artery, the bile duct, and the hepatic portal vein that you all see clustered together there. Now, there will be many substituent portal triads. We'll talk about the organization of the liver later. This is the one that actually goes into the hilum of the liver. The other thing I think would be very useful at this introductory level is to sort of take a mental snapshot of these structures that you see here relative to the surface anatomy, get a good idea of how, for example, the kidneys, the adrenals, where they are positioned relative, for example, to the subcostal margin. Again, that's a good reference point. You can see the iliac crest here. There's only a short distance between the bottom rib and the iliac crest. You can see that's, depending upon a variety of circumstances, the approximate location of the posterior kidneys. So I think this is a very useful illustration. There's something here called the transpyloric plane at about the level of the pylorus. We've talked a little bit about the liver. We can talk a little bit about some of the organizational features that are most important. Nominally, the liver is divided into the right and the left anatomical lobes that we can see here, but bear in mind that anatomical division is mostly affected by this very shallow depression that is associated with the falciform ligament. Remember, the falciform ligament is just a continuation of the peritoneum. It's where the parietal and the visceral peritoneum come together at the anterior abdominal wall. So we sometimes make a distinction between the anatomical lobes of the liver and the functional or portal lobes of the liver. And the portal lobes are more divided along this plane as opposed to this plane. So let's look at the back side and see why that's the case. So anteriorly, you can see the right and the left lobes. This is the anatomical division. But the functional or portal division is along this plane. And it's really a division between the right, a portion of the right liver, and a portion of the right liver plus the left lobe, left anatomical lobe. And it more or less corresponds to, and this is what is important because it helps us understand the anatomy of the liver, the functional division more or less corresponds to the position of the vena cava and that portal triad as it ascends into the right lobe of the liver. Now, the reason that portal division is also called the functional division, and I don't know if I have the illustration here or not. Yes, is because if you look at these various lobes, there are going to usually be 8 of these. These are analogous, for example, to bronchopulmonary segments. And what you'll notice is here's our portal triad, here's our vena cava. There are generally 3 lobes on one side and 4 on the other. And so really it's a lobar partition and a much more logical functional division. That portal triad is going to brachiate, divide, and then supply each one of those individual segments or lobes. The other thing to keep in mind, we've indicated as we talked about the falciform ligament there, that not all of the liver is covered by peritoneum. In fact, the peritoneum has, as you recall, what's called a bare area, which is a region that opposes the diaphragm, directly facing the diaphragm, that is not covered with peritoneum. And it's this portion right here. You can see there's what's called a coronary ligament. Here's our falciform ligament. There's what are called triangular ligaments we don't need to worry about, but it's this region right here, adjacent to the vena cava, that is not covered by peritoneum, called the bare area. Here's that little tongue sticking out, but when you see these images, just hopefully now you'll recall that it's continuous with all of this, It's all part of the peritoneum. And of course, all of that is, under normal circumstances, in vivo, pushed tightly up against the anterior wall of the abdominal cavity, and this would be continuous with that. We've made several references to the lesser omentum between the liver and the stomach. Remember, what is happening here is those hepatoduodenal and hepatogastric ligaments are basically dividing, passing on either side of the stomach, and then reconverging as the greater omentum inferiorly that we saw in the video. And the other thing to keep in mind is the position, because this is going to be so important for not only your anatomical understanding, but for medical procedures. The location, the relative position of the portal triad with respect to the stomach and the liver, going into the hilum or hilus of the liver. This is simply reminding you, the little illustration here, the diagram here is simply reminding you that the liver is sitting on adjacent to the diaphragm, and as such, as the diaphragm moves up and down, the liver is going to be moving up and down with it. And so, anatomical position in this context. Well, I guess the larger point, depending upon whether your patient is sitting, standing, or recumbent, the position of these structures is going to change with each ventilatory cycle. So I've already talked about the lobes. We've talked about the anatomical lobes. There are actually four anatomical lobes, including the right and left. There's the quadrate and the caudate lobe. These are two minor lobes, usually very small, and are usually considered part of the right functional lobe. But again, it's this sort of partition here that is critical for dividing the segments of the liver. I will not ask you to denominate each of these segments, but I do want you to understand the general organization of the segments and the branches. And then you can see that what's going to eventually happen is that portal circulation, the circulation from the hepatic portal, once it passes through each of these segments or lobes, is then going to pass into what are called central veins. Then hepatic veins, and all of that's going to empty into the vena cava. So that's where the magic of the portal circulation eventually ends up in the vena cava by means of the sinusoids of the liver. The liver is an extremely important physiological tissue. It's highly regenerative, but extremely important to the extent that it is critical for regulating blood glucose. It's critical for pumping out literally hundreds of different enzymes and proteins that are critical for systemic metabolism. And so to carry out all of that, it's filtering and processing the blood. We've indicated that it contributes to recycling of red blood cells. To carry out all of that metabolism, it needs oxygenated blood supplied by the hepatic artery. Because the portal blood that ascends from the GI tract is going to be, although laden with nutrients, it's going to be largely deoxygenated. So it's really the confluence of these two vessels, both the portal blood and the hepatic blood, that is passing through the sinusoids and hepatocytes for further filtration and processing. Of course, you've probably heard of cirrhosis. Quick way to, although this is quite a marvel. See what he's doing. This cup has to go in that cup, it has to go into that cup. It's quite an athletic achievement. But of course, with cirrhosis, we're talking about progressive degeneration and scarring of those hepatic parenchyma of hepatic tissue. Initially, it becomes sort of fatty, something called steatosis, and then eventually the steatotic regions go over to scarring and necrosis. And as that happens, the liver loses its ability to do all these wonderful things. And up to a point, the liver can be highly regenerative. I think, depending upon what source you read, you can lose up to 2/3 of the liver and still achieve some measure of regeneration and functionality. But beyond a certain critical point, it's irreversible. And that's the risk that is run in this type of disease. I've made reference to the portal triad. Now here's the, let's see if I have a better picture here. I don't know if I do. I'm a little hesitant to get into this without a better illustration. But that portal circulation is going to ascend into the liver. And as you saw, those portal vessels are then going to brachiate into each of the segments, each of the lobes. And within each of those lobes, there are also many thousands of lobules. So the lobes are made up of hexagonally shaped lobules. Hexagon means a sort of six-sided structure that you see here. And at the apex of each one of those, again, this illustration isn't so great, at the apex of each one of those little vertices of the hexagon is a small portal triad. All right, so we're going to have one of these located here, 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 and so on. And of course, what they're bringing is the portal blood from the GI tract, laden with nutrients and potential problems that the liver must address, potential pathogens or toxins or whatever, that the liver is going to remove. Here's the hepatic arterial blood that's going to provide the oxygen necessary for the hepatocytes to carry out their important mission. And all of that blood is going to be passing through what are called hepatic sinusoids. And the sinusoids are those very, very large blood vessels in which that blood is more or less mixed in between the strands of the hepatocytes. Now, in those, alongside these things, there are going to be affixed macrophages, things called Kupffer cells that are looking for bacteria, potential other problems. But eventually, it's the products and the metabolism of these hepatocytes that's filtering and processing the blood. You can see one of the macrophages lurking back there in the background. The other thing, though, that's happening in these lobules of the liver, as you can see, that bile is being generated, and it's going the opposite direction. It's going into the biliary ducts, also part of the portal triads, but in the opposite direction. So the blood's coming in and aggregating in what's called the central vein. Here's the central vein, central to the lobule. The bile is going the other direction to leave the liver. And then eventually, all of that blood, it's kind of difficult to see here, but all of that blood leaving the hepatocytes is going to be taken in and emptied into the vena cava. Now, at the base of the right side is also, we're looking here the gallbladder. The gallbladder is the storage repository for the bile that's formed by the hepatocytes along those sinusoids. You can see the right and the left ducts converge to form the common hepatic duct, which is going to deliver the bile down there to that hepatopancreatic ampulla, which it in turn takes the bile into the duodenum. But remember, there was a circular valve down there, that sphincter of Oddi. And so if that sphincter is closed, the bile is going to come back, or at least the pressure gradient is going to be reflected. You have pressure here, which way is the bile going to go into those circumstances? It's going to go into this structure, the gallbladder. So the gallbladder basically just collects the bile, stores the bile, until it can be admitted on an as-needed basis into the duodenum. Of course, your bile acts to emulsify fats. So depending on how much dietary fat you have in your diet, that will in large part determine how much bile is released into the proximal intestine. But I do want you to be familiar with these three structures, and I think we have a better picture here. Yes. So be familiar with these three components of that biliary canal system. Here's the common hepatic duct descending from the liver. This is called the cystic duct that empties into the hepatic duct from the gallbladder. And so don't confuse the hepatic duct with the bile duct. The bile duct is distal. The bile duct is what is the tubule that actually empties into the duodenum. And of course, there are a lot of problems that can occur. The liths can develop, the bile can become concretized or lithic. Stones can develop in here. Stones can sometimes be transmitted along one of these passageways, and as peristalsis occurs, pushing the lymph along, a small accretion or lith can block the passageway, and that can be extremely painful. So there are a number of pathologies that can occur. You can see these would be gallstones here, and at this point, that gall is no longer usable. And they can arise from a variety of chemical precipitates, but usually it's super precipitation, supersaturation that gives rise to these. That's enough for today. We'll stop there and then talk physiology tomorrow.